Welcome to our quarterly Global Health Compassion Rounds, which is being jointly convened by the World Health Organization's Global Learning Laboratory for Quality Universal Health Coverage in Geneva, and also by the Focus Area for Compassion and Ethics, or FACE, at the Task Force for Global Health in Atlanta. The purpose of these rounds is to share experiences, challenge ideas, and spark thinking on compassion in global health. My name is David Addis, and I'm delighted to welcome you to our webinar today. At times, compassion can seem rather abstract, particularly in the field of global health, where we work in large systems and complex institutions, and where the human dimensions of our work can seem lost. Compassion comes alive and becomes real when it is shared through stories of human connection. Stories of compassion embodied in real people, specific settings, can inspire us and help us realize the power of compassion in our own lives. Today, 4 extraordinary global health leaders from around the world, Democratic Republic of Congo, Burkina Faso, Pakistan, and Sri Lanka, are joining us to share their personal stories of compassion in their lives and work. I'd like to express my appreciation to all of you for being with us. We're really thrilled that you're here. We'll also be joined by Regina Madingit, a communications specialist with Common Thread and a professional storyteller and filmmaker. To introduce our panelists and guide our exploration, I'd like now to introduce my friend and colleague, Dr. Shams Syed. Shams?
Thank you so much, David, for those really important framing remarks. I'm really glad that we are focusing in on sharing stories of compassion in action in global health at today's Global Health Compassion Rounds. As David has highlighted, nothing beats lived experiences in getting to the core of what compassion means in our world. So our objectives today are fourfold. First, to highlight powerful stories of lived experiences of compassion in global health and continuing to shed light on compassion in action. Second, to connect with compassionate individuals across sectors in global health with a particular focus on quality health services and bringing that linkage to quality of care and quality of health services. Third, discussing the ways that compassion is embodied and enacted and how we can draw on this knowledge to scale up compassion across all levels of global health. And finally, discovering how compassion is transferred, transmitted, translated from compassionate leaders to others on their teams and in larger organizations. And as we go through this exploration, let's try to keep an eye on the compassion equation that we always highlight in these global health compassion rounds. And you've heard David and myself mention this previously, but that compassion equation, awareness, cognitive awareness of suffering, empathy, emotional resonance with the suffering person, and action, a commitment to alleviate suffering, we know is required at every level of the system, from the point of care to health worker interactions, from health facility and district level organizations to national level strategic direction setting, and indeed the global level. And this equation comes to life through lived experiences, and that is particularly why we are all really looking forward to this global health compassion rounds. So how are we going to explore this today? We have, and as David has mentioned, a wonderful line of speakers who will share from the depth and breadth of their experience. So we can explore the cultivation of compassion in global health in a spirit of open learning. And this is, again, at the core of the Global Health Compassion Rounds and the ethos of the Global Learning Laboratory, sharing, challenging, and sparking new thinking. Compassion, as we all know, is an important area, but not without controversy. And that is exactly why we need to learn together and particularly from the lived experiences of colleagues. What's the structure for today? What we'll do is first turn to each of our 4 speakers to share their thinking in a series of interventions. We will then turn to a compassion storyteller for an overall reflection. And following this, we will have a focus-like group discussion in the open to explore key questions with the 4 speakers. We will also be weaving in key questions that emerge from all of you. And so please do place your reflections and questions as you listen to colleagues. You'll see that there is a Q&A box, and please place your questions so that we can weave those in. And maybe we'll get to some of them. Maybe we'll have to follow up post the compassion rounds, but it's important for us to hear your thoughts. We're really excited about this, so let's get on with it. I look forward to listening carefully to colleagues and to learning, and what emerges from these discussions can certainly inform us as we all move forward collectively in the arena of compassion. So with that, let me start with Abraham Leno. So we will be, and all of these colleagues have a very long bio, so I'm going to not speak about them, and that's probably more important to hear from them. So you will see in the chat box the background for these colleagues, but very briefly, Abraham is the executive director of Eastern Congo Initiative and has spent his career promoting health, dignity, and joy in the world's most difficult places. And you'll just have a glance at that further detailed bio in the chat box. Abraham, over to you.
Thank you very much, Shams, and I appreciate being here today. I hope that everyone has had a good weekend and we enjoying our times wherever we are. It's a pleasure to be here and to participate in something that touches my heart. And not just my heart, my own life experiences. You may have heard, I work in Congo, and it's been about 12 years that I'm in Congo, working with Eastern Congo Initiative, but that's not where my story started. I was really born in Sierra Leone, and at age 16, I became a refugee and lived in a refugee camp for 11 years. So within this 11 years of refugee situation, I was at times separated from my family and lived in different locations, and there was no contact with family members. While at some time I was away and my family was in Guinea as refugees, I had to return because there was no English school for the level of school that I was at. The grade that I was in, they didn't have an English curriculum in the refugee camp. So I had to return in a war situation in Sierra Leone to go back to school. And while I was there, a continuation of wars continued. And a tourist came from Holland, met my family, and he heard about my story. My family wanted me back, and well, there was no way. I was already caught up in another war in Sierra Leone, and there was no way for me to come back. And this guy finished his tourism and went back to Holland, but continued to keep in touch with my family, asking them whether I am back into the refugee situation. Well, I finally managed to come back, but I did not want to stay. The reason being that I wanted to go to school and I didn't have any opportunity to go to school. And the only opportunities that were at that time were private schools that were very expensive for a refugee family to enroll into. So he offered to pay for my education. And his kindness, his generosity, his compassion, understanding how my family, the issues that my family and I dealt with as a refugee, helped me to go to college. And I finished college and went back to working with refugees. You've heard from Dr. Shams that I've worked in some difficult places in the world. I've worked in Darfur, in Sudan. I worked in Pakistan. I worked in Liberia, in Guinea, in Somalia, and Ethiopia, and now I'm in Congo. His influence or his work of compassion, his touch of compassion in my life changed me. Today, I'm providing healthcare services in some of these remote places, in some of these difficult environments. But here is one thing I really want to highlight about this short version of my story. I have never met this guy. Till this day, I have never met him. So I completely believe in compassion. I believe that it works. I believe that it can be translated through human contact, but even without human contact, we can still influence others through compassion. So I'll be talking about the work that I do in Congo later, but I just wanted to share the context of where my compassion and what motivates me to even be here and continue doing this work. Over to you, Dr. Shams.
Thanks very much for bringing us to that, Abraham. Please go ahead and tell us a little bit more about your experience and your lived experience of compassion. Over to you.
Thank you very much. Well, over these years, I have been around working in refugee camps. So part of what marked my life also as a refugee was the fact that when you go into a refugee situation, well, I think what an appropriate time to even be talking about refugees, because yesterday was World Refugee Day, as most of you or everyone here would know. What you get is a number. You get a number, and that's not even the first day of you entering into a refugee situation. Maybe weeks and months down the road, when the UN systems appear, they provide you a number. And there's a number that you are identified with. Most of the time, that's the number that replaces your name. And this was very strange for me as a young person. I was 16 years old, and all I could be referred to was something A00 something. And it feels like you lost. All right, you go into a refugee situation in the refugee camps. Unfortunately, most of what is provided is really provided on your behalf. There is not, you don't have any form of participation into what you receive, whether it's in education, in food, or in healthcare. And unfortunately, sometimes some of the food that we received was nothing that we used to eating. We were provided bulgur wheat. And one of the instances, the wheat that we received had expired during transport from whatever country it came from. And it became a cause of cholera in the refugee camp where we lived. We didn't have a choice. That was the food that was provided for us. So what is that experience for me? It was almost this notion of refugees, numbers, refugees and beggars do not have a choice. And so this also translated in a number of years. I have worked in the humanitarian sector for over 20 years. I also saw the same kind of activities implemented in forms of how we develop our proposals without any context, without any involvement of local communities. So what is their desirability? Treating them like, vulnerable people. Those are the categories that we call them, vulnerable people. So we behave on their behalf, we act on their behalf and write proposals. And after a couple of years of working in this manner, I really rebelled. I remember I resigned and I sent my organization, then I sent them a letter and I said, I cannot be loyal to something like this. I am perpetrating the things that I didn't like about my own refugee status or my own displacement status. These were the things that I ran from. I left the refugee camps and became really a refugee in host communities. I was selling fuel on the street in bottles just so that I can make it, so I don't have to stand in line and be treated like I don't have a choice. So coming back to what I do in Congo, this was at the basis of what I wanted to change. Inherently, first of all, involving communities into participating into what we build, the quality of what we build. There are some things that have scarred, if I will call it that way, scarred the humanitarian sector. We're going into communities thinking that we have to go in with an exit plan. And so that exit plan also defines the short-term nature of our activities and the disruption that comes into communities. I went to Congo and in 2010, And what I met was in a small place of around 800,000 people, there were over 200 registered organizations. Today, there are not even 15. Now think about how much disruption that has caused in the lives of people. They coming and going, all of the refugee. So there's no established relationship. There is no partnership within this form of building. And because we are so mindful or so, thoughtful of having an exit plan, we tend to build mediocre because we're not going to be there to use it. And I wanted this to change. And I said, okay, we want to build something that we can use, that we can come back and be proud of. So eliminating this us versus them. The things that I build in either the water and healthcare systems, I'm proud to use. I took my children from the US a couple of years ago, and the immigration guys were, oh, you have a 9-month-old baby, why are you taking them to Congo? I said, well, I know what I have there. And I went, the vaccinations, I took them from the clinics that I am providing for others. The water, I drink with my family. And so that eliminates this notion of us versus them. The structure of the communities. In Congo, one of the things we noticed, there is this language, they call a sick person, they call a patient, they call them the sick person. So the area for triage is usually very far from where the services are provided. And when we discuss with our communities, what has affected you in the way that healthcare is provided? Well, they said, they call us the sick person. So nobody really cares. We are the patient, so we have to be patient, whether the nurse is there or they are not there at all. We are the patient, we have to wait. The medicines, there are no medicines available within the healthcare systems. So we come here only to see this person that arrives when they want to arrive and they leave when they want to leave. So these are some of the things that we've tried to change. We've tried to change also the way that we actually talk. One of the things that we do in our clinics, when you go in, we greet you and we tell you you have a right to be here. And that, for me, is a personal thing. For 11 years in a refugee camp, not in the healthcare system, not in the water system, not in the education system, did I ever hear the words, you have a right to be here. And we make sure that people who come to our clinics now in the Congo, that's how they are greeted. And it changes their perspective. They go from being that vulnerable person that we consider them to being a client. We don't call anyone vulnerable because we all have vulnerability in some time and space in our life. We call them clients, customers. We run social enterprises. So we treat them like customers because our work depends on their acceptance of what we do, and their acceptance of that work makes us continue. We want to build for sustainability, but not if we continue treating them like the vulnerable people that we brand them as.
Abraham, thank you so much for bringing all of those perspectives so clearly to us today. I'm now going to turn to Nida Ali and to hear from her. And you'll see her full bio in the chat box, but very briefly, Nida is a medical doctor and a public health professional, and she has worked 4 years in hospital-based settings in the departments of emergency medicine, gynecology, and obstetrics and sexual and reproductive health. And she's also worked extensively in the immunization arena. So Nida, over to you, and looking forward to hearing your perspectives.
Thank you so much, Shams, for this introduction. And I'm so glad that Abraham spoke before me, because the story that I'm going to tell is actually a similar perspective and kind of a continuation of what Abraham said. So as Shams said, I worked as a medical doctor in the field of OBGYN as well. And when I got there, what I did was mimic the behavior of my seniors. This is how we usually learn. We tend to see how our seniors are behaving, and we tend to internalize that. So this is what happened to me. Imagine a country of 260 million people, and there are only a handful of cities with quality healthcare. So obviously the public hospitals in those cities are hugely overburdened, and this overburden causes doctors to be overburdened. So when I was in OBGYN, it was quite a norm for me to perform 8 deliveries per day and assist 2 to 3 cesarean sections. And this actually takes a toll on us because we are on call for like 36 hours. So my point being that doctors were really, really overburdened. And in context of being so overburdened, they fail to empathize with patients. Like I literally performed deliveries on patients I did not even ask names of. And, while doing all that work, the tough work, the female being in pain and helping her to deliver the patient, deliver the baby, deliver a completely new human being. And, it was very hard for us to actually connect with the patient when we have another patient in labor on the very next table. So I saw my seniors being actually rude to female patients in that settings and not connecting to them, not behaving like they feel their pain. And I internalized this behavior, and in a few months, I was institutionalized by this behavior. So the only thought that came to me when I was at the patient's end was when I used to stitch the episiotomy. Episiotomy is the incision that we give to a woman when she's crowning, which is a very painful thing. And I observed that some doctors even did not apply anesthesia properly before performing episiotomy. So the next stage is stitching the episiotomy, sewing a woman's vaginal walls in layers. And that in itself is a very painful procedure. So giving the proper anesthesia at that time is very important, but sometimes doctors were so busy that they just didn't care about it. And seeing patient in that kind of pain actually gave me a pain being a woman. So that was actually very short duration when I was able to feel compassion. And it was just a very small practice of spraying the anesthesia at the area that we are operating on. And this used to give a considerable relief to patient. Like I used to do that to patients to relieve their pain to some extent, because even that local spray does not completely alleviate the pain. So this is something that I felt like as a woman, because one day I would have to be on the same table. And to be honest, the day when I was on that table in a very good private hospital where I was paying huge money for, I experienced the similar things. The doctors were overburdened even in that private setting, and they told me to cooperate more when they were, doing exams on me. And I can remember how hard the labor pain was. And, during that, the doctors are not being empathetic to you. They are not speaking like in a very connecting way. So it was very hard for me. And then I realized how hard it would have been for women who were coming to government hospitals, which were not even very clean. And we were routinely being rude to them. We never asked their names. We never connected with them. We never had any chat about it. So, this breaks my heart. And unfortunately, this is the situation that is still prevailing in those settings. But now the lesson I learned was that no matter how busy I am, I'd always ask my patient her name and chat with her a bit, show her that I care, and then tend to make the process more comfortable and easier for her. Because at that point, there is a lot that is in doctor's hand. And if doctor is being very compassionate, very sympathetic or empathetic with you, I know it has an impact on patient's mental health. So it's all about the behaviors that we internalize as doctors. And if I could go back in time, I would definitely behave differently. And if I am heading a department of gynae and obs now, I will definitely prioritize being compassionate. And I am pretty sure there are ways to be compassionate despite being overburdened, because this is the setting that we have to live in. We will always be overburdened because the health facilities, the health sector is not adequately financed by our government, and we will always be under-resourced given the huge population in our country. So this was one perspective of how we behave with patients rudely and how we should behave with them. And there is another public health perspective of having a compassion. And this includes an example from northern Pakistan, where I was actually doing the outbreak response. And I came across a woman in the field who was washing her clothes at the bank of the river without any soap. The community did not have any concept of soap. That is why there was outbreak of so many diseases. and there was open defecation and people had no concept of washing their hands. So I approached this woman who was sitting at the bank of the river and her children playing by her side, and I talked to her about vaccination status of her children. But when I got into conversation with her, I actually learned the sad reality that she was actually worried what her children are going to eat the next day, because she didn't have any money for the next day. I mean, she was able to afford the next meal, but not for the next day. So she was worried about that. And in that context, I'm going up to her and talking to her about vaccinating her children. She could not care less about it. So, this is how we talk about community transformation, that we have to be connected enough to the community first to understand their need and then send our message. So this is pretty much from my side. Over to you, Shams. Thank you.
Thank you so much for that, Nida, and bringing very clear and you can almost visualize that lady that you were speaking to. Two powerful pieces of personal reflection from Abraham and Nida. I'm going to now turn to Yolande and we'll hear from her. And she grew up in Burkina Faso, and you can see the full bio in the chat, where she experienced health inequities. And really that changed her to dedicating her time and energy to serving in a compassionate manner. So you can see that she's completed her medical studies and a specialization in cardiology, and has been working in public hospital sector since then. Yolande, over to you.
Thank you so much. It's really a great pleasure for me to be here, and I'm really excited to be in this webinar. So I have to talk a bit about where I'm coming from. In Burkina Faso, our health system, the model is the pyramidal one. And from the top to the bottom, we're having the peripheral level, the intermediary level, and the top we're having the university level. And as far as I'm concerned, I had the privilege to work at all the level of our health system. So at the peripheral level, I have worked as a generalist practitioner. So when I finish my medical studies, I have been in the communities. So I work as a generalist practitioner, and then I have been appointed head of district. It was really a great opportunity for me to learn with communities, to be in touch with them, and to know a lot of things about them and to learn from them. Apart from that, I had also the opportunity to work at the secondary level, and it's where I'm now. I'm a cardiologist, and this is the regional level. The regional level is the level where we are having a lot of people, a lot of medical doctors. Some are specializing, some are generalists, and we are working together in collaboration for the well-being of our patient. And for the last level, I have worked when I was under training for my specialization at the university hospital, the biggest one of my country. So this is a privilege for me because I have been involved in all the steps of our health system, and this helps me a lot. As far my story is concerned, and in my daily activities where I'm working now at the regional hospital, I have to perform what a medical doctor specializing in cardiology is doing, like to help doing medical consultation. And I have to say that I really love it because I'm really involved in the clinical management of my patient. That is something very, very close to my heart. And we are working there. And what I'm doing is to perform some examination related to the heart, and also to help some colleagues when they need me to help in order to manage some patient. But this is the common component we all know. But I have found that the other component that is really interesting and important is how we are able to take initiative. And this happened to me many times, how to take initiative, how to be innovative in order to improve the management of my patient. So it's not only doing what I'm supposed to do, but what I can do to improve the health of my patient. So I have realized that most of the time, it can be what I'm doing it can be giving more explanation on my patient. So for some patient, I will do like a specific sensitization on a kind of specific disease regarding the heart for them to be able to understand more. It can be how to get the relatives one involved in the management of the patient. It can be how to get in touch and to create or to be in touch with a multidisciplinary team of other medical doctors in order to see how we can get involved for the better management of the patient. It can be how we can get the social office involved in the management of the patient, because some of my patients, when they are there, they cannot afford medicine. So after that, I have to check, make sure that I'm having in touch with the social service for them to get them to help buy the medicine. It can be also how to support their mental health, because some of my patients, it's like the first time we met, they worried about everything. So it's good like to talk and to see how to support them. It can be also how to adjust the need of the patient. You know, some patients may be in specific condition. Maybe they are far from the university, they are far from the hospital where I am, and I have to wait for them because on their way coming to the hospital, they have some issue and they say that we will be late. So I have to wait for them. And also some of the patient is like, they're having specific need and they need the doctor to provide. And it reminds me the case of one of my patients. And in order to be like this, I have to practice warm welcoming. I'm glad Abraham talked about it, warm welcoming, and to be active listening in order to know more about my patient. And once you're doing it, you can know more about your patient and see what is the specific need of the patient. So I have to say that, you know, from one patient to another one, the specific need may be different. And how to get access to this specific need is to show warm welcoming and to be to listen carefully so that you may know what is most important to your patient. And this is having a case to share. One of my patients, he is a teacher working in a public school, and he was referred to my consultation because he was having blood pressure, a high blood pressure. And when we met, he really worried about his situation. And it was like what I did is what I just said. I practiced warm welcoming and active listening. And at the end, I have discovered that what is specific, the specific need of this patient is he needed to talk a lot and to learn more about his disease. And he also needed to get his beloved one involved in his management for the treatment to be efficient. So what I did is like, I gave him time and I explained him all that is important for him to know about his blood pressure. And on top of this, his wife, his brother, and his superior, the head where he was working, they were all involved in his management. So what I did, I met his wife and I talked with her to give him some advice on how to cook healthy for my patient. I also meet his brother because his brother he has authority in him, and his brother needed to know more about the treatment of my patient. So it's what I did, I explained everything to his brother in order to help his brother to help in case of need. And for his superior, I have written a letter to him, not to expose the situation of my patient because it's not what I'm doing, but to let him know that my patient is experiencing some like specific situation and it's not too good for him to be in too much pressure. And my patient was teaching a class of more than 100 kids. So after that, the superior was able to remove my patient from that situation and to bring him to the office where there is less pressure. And what happened is like, at the end of this meeting, I was really impressed by my patient because he could know everything about his treatment. And he was like a health champion because he was the one in the community, like using his case to sensitize other people. So sometimes he will reach out to me, calling me on my phone and telling me, doctor, do you know there is someone here suffering from blood pressure? I would love you to take care of him because I don't want him to suffer from the complication of blood pressure. Another day he will call me, doctor, there is someone here. He is out of medicine and I'm trying to convince him. Please, can you do something for him? So, you know, what I have learned is that my job is a cardiologist, but while I was dealing with this patient, it's not only the heart I was dealing with. I have to deal with all the environment, his work, his relatives, and his mental health in order to help my patient to be in good condition. So deal with heart is good, but I have to consider to have a holistic view of my patient, not only his heart, but all the environment that can make the treatment efficient. So that is about what I have to share.
Yolande, thank you so much for that. And you've articulated it so beautifully and so clearly. And let's turn now to the fourth of our distinguished speakers. And if I may, if I can turn now to my colleague, can I come to see if we can now come to Neville, Jessica, who's a physician with postgraduate qualifications in disaster management, community medicine, diplomatic studies and foreign relations and human rights and peace education. So again, we'll see his bio in the chat box. But if I can come to Neville. Neville, over to you.
Thank you so much, Sham. Yeah, so once upon a time, there was this tiny boy who was probably 6 years old, and he was playing in the backyard of his aunt's house, and he heard the voice of two little birds that have fallen into a big pit. So this young boy was brave enough to bring a ladder and climb down and bring up the two little birds to rescue the two little birds. So after some time, this boy told his mother that he wanted to be a doctor. And this little boy was me. So I had this little boy troubling me all the time. When bad things happen, he is troubling me that he wants to go and help them. So I had a very deep relationship with this bird rescuer boy and myself as a medical doctor. So I was very much touched, as Nida also mentioned, by the story of Abraham. I had the opportunity of serving the internally displaced people in the aftermath of the 30-year-old conflict in Sri Lanka. So I just went there to serve for 2 weeks, but the bird rescuer boy really did not want me to come out of that place for almost an year. So he actually helped me to be in the field of disaster management. Being a Buddhist, I'm very much inspired by the story of Bodhisattva Avalokitesvara. So Bodhisattva Avalokitesvara is a character that comes in the Buddhist history. So a Bodhisattva is a person who wants to become a Buddha, but he's not yet a Buddha. So this particular Buddha was full of compassion. So he's called the compassionate Bodhisattva. So he was thinking too much about the suffering of the world. And he was so concerned and he was so touched by the suffering in the world. So one day his head split into 10 parts. So he had not only one head, but he had now 10 heads. So he rushed into a Buddha, Amitabha Buddha, and told, look what happened to my head. Then the Buddha looked at this Bodhisattva and he was very compassionate. So he said, okay, let me give you 1,000 hands so that you could go and help all the people that are suffering. So this Buddha or Bodhisattva is often depicted with hundreds of heads and thousands of hands and trying to help people who are suffering in the world. So this has been a very touchy symbol for me because the bird rescuer boy really, really loved this story and this passion to help those who are in need. So as you are aware, we are going through the worst times of the history in Sri Lanka. We are going through serious financial crisis. We have near zero foreign deposits of foreign currency, and people are having really hard times, and food security is a big problem. Now, this birds rescuer boy was troubling me again. Of course, I was in fact in US. So this boy was not leaving me alone. So now the boy wants to go and do something for the people who are suffering. So my instinct is I should always listen to the boy. He's 5 years old, but he's so mischievous and he's full of energy. So I can't ignore him. So I said, okay, yes, let's do something. But the problem is so big. How can a small boy and myself go and help the problem of hunger, the problem of food insecurity? This is a massive problem, over 5 million people affected. So I was thinking, oh, I wish I would be like Bodhisattva Avalokitesvara, where I had 1,000 hands, so I could go and help all these people. But we have only 4 hands, my 2 hands and the 2 hands of the little boy. But we were able to get connected with an energetic and amazing group of youth volunteers. So instead of 4 hands, now we have more than 100 hands to help us. So we were able to work with these young people, motivate them, infect them with the compassion that we were sharing. And now the little boy was not only troubling me, but was also troubling these 25 energetic young leaders. So with them, we went and did a emergency food supply project. So this was supported by some expats from New Zealand, but it was totally run by this amazing group of young people that we identified and coached and mentored and was sent to the field to help the people. So today we launched the Little Food Cabinet program, inspired by the amazing people of the United States who have launched a project called Little Free Pantry. So I adopted it to the Sri Lankan context, and we would be launching the Little Food Cabinet project. We means the little bird rescuer boy, myself, and those amazing group of young volunteers. So reflecting for this session, I was able to conceptualize suffering and what we should be doing when we are faced with suffering, as in case of the current crisis in Sri Lanka. There are 3 pathways: the black pathway, the blue pathway, and the red pathway. When we have suffering, we can get engulfed in the sadness, hopelessness, helplessness, and then we would evoke a flight response, and we would try to withdraw from the whole thing with sadness, and then this would in turn aggravate the suffering. We could also go in the red pathway, where fear, mistrust, and anger would prevail, and we would be pushed towards fight, and which could lead into violence, as evidenced in Sri Lanka over the last few months. So there is a middle path, the path of compassion, the path of care, and path of hope, where we could take action to reduce the suffering, the path of solutions. And this could not only limit suffering, but also could promote the well-being of the community. So myself, the bird rescuer boy, and all my community that has been influenced by this little boy, at times troubled by him, are on a journey to make our world a better place with less suffering. Thank you very much. Over to you, Sham.
Noville, thank you so much for that. Now, we've heard from 4 really beautiful experiences of life, and our speakers have been incredibly generous in getting to the depths of their personal experience and sharing that with us. I'd like now to turn to Regina Madung-Git, who is a storyteller who can give us some reflections on what she has heard today. And Regina's bio will be in the chat, but just in brief, Regina is a Filipino-American storyteller and designer based in Chicago, and she leads communications at Common Thread, crafting multimedia narratives and experiences for their global audience. So, Regina, you've heard from the 4 colleagues. Your thoughts, please.
Yeah, absolutely. Thank you, Shams, and thank you so much, Novelle, Yolande, Nida, and Abraham for sharing those stories with us. It's really inspiring to see how you've taken what you've seen and experienced and carried it forward and tried to make a difference in the work that you do. So I just want to take this moment with everyone here to just digest a bit and sit with everything we heard. So I don't know about all of you, but hearing these stories really brought up a lot of different things for me. And it's kind of hard to put into words what I'm feeling, but that's exactly what I'm here to do. So I'm going to try, if you'll try with me. So if you'll join me, I invite you to just close your eyes and take this moment to just check in with yourself. And if you open your eyes and you see my eyes open, I'm really just trying to keep an eye out on the time. So no, you didn't. So with your eyes closed, the first thing I'm going to ask you to do is just pick out a moment, something from you've heard today, a scene, an image, whatever just really stood out to you. And maybe when you heard it, you felt something in some part of your body. And I know there's just a number of things you can pick from, really. Like, the stories were so rich today, but just try to pick one. And so for me, that was when Yolande said, it's not only the heart that I was dealing with. And I really felt that in my chest. And yours might be the same, with a different sensation, or it might be the same sensation, but a different moment. And that's kind of what stories do. We take them in, and they live differently inside of all of us because we're all different. So take that moment, that scene, that image, and just like project it on the movie screen in your mind. What do you see? What do you smell? What do you hear? What does it remind you of? Who does it remind you of? Why? For me, when Yolande said it's not only the heart that I'm dealing with, it really reminded me of my rheumatologist. So in high school, I was diagnosed with a chronic illness like my sophomore year. And so I started seeing a child rheumatologist. Her name was Megan. And on our first visit, she asked me to rate my pain on a scale of 1 to 10. And then she asked me to give her a rating of my life on a scale of 1 to 10. So what would my life score in general just be on a scale of 1 to 10? And so over the course of the next 2 years, I would see her every couple of months. And at the beginning of every session, she would ask, okay, rate your pain on a scale of 1 to 10. And now rate your life on a scale of 1 to 10. And at our very last meeting, she told me that over the course of my time seeing her, that my pain, the way I was rating my pain, had gone up, because she was recording it every time, and my life score had gone down, which might not be the best testament to me improving under her care. But to her, it meant that I was being more honest and more willing to accept and admit that I was in pain and that I was struggling. So when I hear Yolan's story and I picture it in my head, in my mind, Megan is there and I'm there. And that's just the really powerful thing about storytelling, is our ability to see parts of ourselves and moments from our lives in the words and experiences of other people. Just another one that stands out in my mind is when Nita said, as a woman, one day I would have to be on the same table. So I hope in this reflection that, and whatever you're picturing, to just hold on to what you're feeling in your body and hang on to what you're being reminded of as you've heard these stories. And I'm really excited to just unpack all of that with you in the next discussion. So I invite you to open your eyes when you're ready and we can go and dive in. Thank you. Thank you so much for all those stories.
Thank you, Regina, for those reflections and helping us to also feel some of those feelings that that the colleagues have inspired in us today. If I may ask all of the colleagues to perhaps join us and place their video on, and let's have this next part of this is really to focus in on some key reflections and key questions that I'm sure folks will have. Maybe I'm going to start with one particular one, which has been brought up by each of you, but I'd like for you to perhaps go a little bit deeper into your thoughts on this. So each of you have shared really personal stories, and again, sincere gratitude for being able to share that openly. In a nutshell, what do you think made that compassionate encounter possible? And if you look back at those compassionate encounters that you've all described, and you've actually described a number, can you give us the essence of what made that compassionate encounter possible? And if I may, I'll start in the same sequence and go from Abraham to Nida, and then to Yolanda, and then to Nabil. Abraham.
So my story of the guy who helped me out and who paid for my education, it's been a very long time. And since I had not met this guy, a couple of years ago, I was with a fellowship that wanted to get in touch with the guy. And he said, so we tried to look out for him. I didn't have his contacts. Thank goodness for social media. We went through LinkedIn and Facebook and everywhere and found him. Long story short, we reached out to him and said, well, here is somebody who is telling his story and he's reflected your name. He's called Gerald Dams. And he said, well, I feel so honored, but I don't know this guy. Of course, he doesn't know me. I was just a refugee somewhere. He's never met me. So I asked specific questions. Did you meet members of my family? Were you in this country at this time? He answered all yes. And then I told him my household name, which was Junior. Did you hear of a boy they used to call Junior from this family? He said, yes, I remember that. So I said, well, I'm the Junior. So this is my name now. And then I told him, and he said, well, I have something to share with you. He said, when I went as a tourist, I was actually with a childhood friend of mine. And I didn't have a lot of money then, but his parents were quite wealthy. And when I came back, I heard your story and I wanted to support. I asked his mom to support you. And all the while that you were in college, I used to send my report cards to this lady that I never knew. I thought the lady was his secretary. So I said, did you have a secretary? Do you know this lady, Miss Iconin? And he said, yes. And I said, that was a secretary that I was in touch with. And I used to send my report cards to them and all the way to this year. And he said, oh, so let me just tell you, that lady was really not my secretary. She was the one that paid your college fees. So what do I bring here? Is generosity through connection. It's hard to frame like what is that element, but it's our shared humanity. Is you looking beyond complexion, ethnicity, origin, and saying, this could, like the story he shared, our colleague shared with the small boy. I used to love climbing trees, and as a small boy. I can see our shared humanity in that kind of a story. I think that is what brought this out. He saw that he had an opportunity to be human and extend that human irrespective of who it touched. And that is what I also noticed, and I said, okay, I'm going to college. I graduated. Before even I got my results in my country, they will announce the results on radio. I went back to the refugee camps. I said, this is where my story begins. This is where I'm going to take it. And that has taken me to places. I'm happy to see, I'll call her my sister from Pakistan. I lived in Balochistan. Up to this day, I have people there, in Sudan, in Darfur, in all of these places that I've been. But that's what triggered it. I think we all have it in us. And there's something that I often say. I know we do care a lot about numbers in the work that we do, but in the story of compassion, I look at it through the lens of one person. If you can do it right for one child, you can do it right for many children. If you cannot do it right for one woman, you cannot do it right for many women. And that's how I look at our job, at what I do.
Abraham, thank you so much for that. And you've captured it so beautifully. What made the compassionate encounter possible for you, Nida?
So the answer is empathy. Only when I was able to feel on a personal level how it would feel. Being a woman, when I saw another woman bringing a human life into this world and going through all that pain, the least I could do was not be rude to her. And also the woman who was washing the clothes at a river, after I connected with her from mother to mother, I realized that I cannot even imagine my son not having his next meal or me being worried about not being able to afford food for him. So it was just empathy. And I realized that the difference that I can make by going in the field is by saving one life, immunizing one child. If I do that right, the rest will take care of itself. Thank you. Over to you, Shams.
Thank you, Nida. Very clearly articulated. Yolanda, can I come to you on that same point?
Yes, thank you. And I have realized that I cannot be doing anything except being a medical doctor because I really love it. And early in the secondary school, I have decided to become a medical doctor. And when I got my baccalaureate, I had to go to the university and I asked them, we have to make 3 choices. And I said, can I just put medical doctor for all the 3 choices? They said, no, it's not possible. You just have to make 3 different choices. I said, okay, I will just put medical doctor first. For the other choices, I will put back. If I'm not a medical doctor, I will wait for next year because I really wanted to go to medical school. And hopefully I have been selected to become a medical doctor. And I'm like, every day, I'm really happy to be a doctor. And this reminds me also, when I was at medical school, the 4th year student, I took the initiative to take care of a patient who has been admitted in emergency because he was in critical situation. This was not my duty, but because I was so happy, I wanted to become a doctor early and I wanted to be involved really. I have taken the initiative to talk to the parents And to meet the patient need to ask all the questions, what I can do. And it was not even time for me to be at the hospital at that time, but I have waited all the day there to meet my boss. And when I met the boss, I was not the one supposed to talk to him, because it's like in medical school, you have what you have to do. But me, I said, no, today I'm going to show him what I can do. So I went to the boss and I explained all the situation regarding this patient. My boss was so impressed. And he told me, wow, congratulations, you are not doing well. And on that day, this was an important day for me. Even today, when I think about this day, I feel very happy. So it's like my vacation for me. It's like to be a medical doctor. And every day I'm full of joy to be a medical doctor. And working with my patient is really something very, very important for me. Sometimes I even forget to eat because I feel happy. So I'm like, where I have to be. So that's really, I love it. So I don't know how to express it, but I love it.
Thank you, Yolande. Thank you. Nabil, coming to you, what has made that compassionate encounter possible in your lived experience?
Yeah, I think making the little boy to survive and making that little boy legitimate and keeping the space for the little boy is the one that made the compassionate encounter possible. Because what happens is our medical education sometimes, our hospitals, their administrations, our ministries of health are too grown up to the point that they are so dry. And compassion is really, really scarce. They are always out of stock. Compassion is out of stock. So I think we should have that little space, that little sweet spot of compassion, and we should be intentional of keeping that sweet spot and that amazing, powerful little boy alive. So I think that's what I have to comment on that.
Very nicely put, Nabil. So let me come now to something, and actually it picks up exactly on the point that you've made just now, Nabil. Each of you mentioned the linkage between compassion and quality of care in the services that are provided. I'm going to go in reverse and start with Nabil, then to Yolande, and then to Nida, and then to Abraham. What in your mind is the linkage, and in your experience, how can we use that compassion to drive quality of care and quality of health services? Nabil, turning to you first, and then coming to Yolande.
Yes, let me start with what Abraham mentioned earlier. As he shared his experiences as a refugee himself, he said that refugees did not have a voice and they did not have a choice. So I'm talking from a public health point of view, from a humanitarian response point of view. The compassion lies in dignity. The compassion lies in allowing the people to speak. And the compassion lies in listening to the communities that are affected by disasters, emergencies, and pandemic. And we have amazing tools such as the sphere standards and the humanitarian charter, which are really, they're talking about compassion, but I never see the word compassion, but I see that these things, dignity, respect, need-based service provision, all those things are fundamentally based on compassion. So I think there are enough tools that we can use to make compassion possible. And we have to be, as medical directors, managers, and medical educators, it's our duty to tell the students that it is okay to be compassionate. Sometimes being compassionate can be seen as a weakness. I mean, if you are as you mature, as you become more senior in your hierarchy, you should be like, you should become more lifeless. That's what we see. You should not be feeling. I mean, you should do what's right, and that's it, forget it. No, I think it should change. Compassion is so important as people go up in their career, as they mature. So we have to affirm that it is okay to be compassionate. Thank you, Sham.
Nabil. Thank you, Nabil. Yolande, particularly, I wanted you to reflect on that same question, but you've had so many different roles at different levels of the system, and particularly one that often is forgotten, the critical importance of district health management in health services and systems. Where does the compassion need to factor into quality of care and services, particularly as they're organized in districts?
Thank you. I think that compassion is really important in trust building, because with my experience, I have realized that trust in the health system is really important, because it's what is like making things possible for you. And once trust building is there, you can have, like, as I'm concerned, for example, for chronic disease, you need someone to take medicine for all life. Most of our medicine is everyday taking the medicine. So trust building is really important. And how do we build this trust is what I just explained. Trust building is at the beginning or the first level. When we meet the patient, it's important to build this trust building by having time to listen carefully to the patient, to practice warm welcoming, and to focus on the need of the patient. Once you get this, the patient is like able to express everything. And once everything is expressed, you can now know what you can do for this patient, and you can meet his specific need. I have to say that, we are dealing with patients. I'm a cardiologist, but sometimes I have to deal with the specific need of the patient and to focus on what is really important to the patient. And when this trust building is there, it's giving me opportunity to even have the patient for the treatment, have the relatives involved, and for at any level of our health system. So as I said, even at the peripheral level, trust building is important, because it's like people will come. At the regional level, trust building is important, because we have to take care of patients and to refer them to the peripheral level. And at the university hospital level also, trust building is important, because we are dealing with investigation. And this is what can build our health system, because it's like it's a kind of partnership. So trust building is, to me, is something very important in the health system.
And thank you for Yolande. Thank you for that, Yolande. And you're bringing in the building blocks of health systems in a very different way to the traditional. And I think that's something that is also coming out from all of your perspectives, is that there's the individual aspect, which builds into something systematic. Nida, you've referred to quality of care issues in your experience. Could you reflect?
Yes, of course. In my opinion, compassion and quality of care are directly proportional. So at the time of care provision, there is a lot that is in doctors' hands, and patients' decision-making is largely influenced by doctors' opinion, because patients trust doctors. So this power, it needs compassion, especially in the critical life-saving situations. And like you talked about compassion equation, doctors are essentially alleviating suffering, but in the situation that I presented, essentially without the awareness of suffering. So if we bring a little bit of compassion into it, definitely the quality of care will skyrocket. Thank you.
Very succinctly put. Abraham, turning to you.
Yeah. Yes, I want to touch on two things, actually. One, and it's all within the comments of my colleagues. One is actually the power dynamics. we need to look at the power dynamics. If we take within our societies today, everybody knows the power that comes with the police or the law enforcement person, but also medical staff. They carry a lot of power, a lot of authority, and a lot of respect. So in the space that we want to build trust, we need to also emphasize the relationship that our medical persons can build, not just within the clinic where they serve, but also in the communities where they live. I think it's very important that we are not just, preachers like shovel preaching. The shovel only takes the sand away. It doesn't reflect on itself. If our medical staff, if our medical teams are not using the services that they provide within communities, what message does that give to our communities? If our doctors, I will challenge even my doctor that is in the healthcare from in the district level, when the district health manager does not go to the services or the clinics that are under his district, he goes outside of his country to seek healthcare. What does that say in building trust? So we need to understand the play of power there and how we can build trust in the way that we also relate to our own communities in the services that we provide. That's why I mentioned, we don't, in all the clinics, all my colleagues, my staff, everybody involved, we are the first utilizers of the services we provide. We have to be able to embody that. We have to be able to speak by example. That's translating it and saying, we're not just saying it, but we also live in it. Another thing is I would say we have to be aware of capitalism. Somebody mentioned in the comment how commercialization within healthcare has also taken away the elements of compassion. Sometimes we are looking, I mentioned this earlier, in the way that we want to attract numbers. We are looking at metrics for, the volume of people we serve, the profit that we make for our healthcare systems to keep them running and all of those. And sometimes this tend to drive how we provide those services, the time that we take with our patients, the way that we construct our facilities to be able to accommodate that dignity that we're talking about. We tend to look at the mathematics of the numbers in terms of what the cost is and forget that it is about humans.
Abraham, some really great perspectives. Now, I'm going to become a little bit controversial, so excuse me for that right from the beginning. So you've heard each other make some very powerful statements about experiences. And while remaining completely respectful of those experiences, I'd like to turn to each of you for something that you heard from the other colleague that really, really resonated, and something that you might just even slightly disagree with. Be bold and be happy to challenge each other. Something that resonated with you and something that you might even slightly disagree with. So we'll mix it up and we'll start with Nida and then move to Novel, Yolanda, and then Abraham. Nida?
Yeah, so what really moved me was actually listening to Abraham and the stories that he shared. So what really resonated with me was the story of a man who helped him complete his education. And in turn, Abraham contributed back to the society. So that man not only saved that one boy and his education, but the impact goes way beyond that. So this is what resonated with me the most. The thing that I slightly disagree with is, again, like how Abraham put it, refugees don't really have a choice. I agree with that. I have seen the refugee settings and I completely agree with that. They don't really have a choice. They are very under-resourced. They are dealing with disease outbreak and all of these things. But what I have seen in these people who are living together in the times of crisis, it is the sense of community. They are very well connected with each other and they have this power about them. They help each other, they share the meager resources that they have. And whenever we want to approach these refugees, we actually approach them from within them. This is how public health operates. Like we go to the elders in that community, and then we sit with them, and then we learn what their problems are. So it's actually the refugee community that is guiding us what their problems are. It's actually them who are training us about what they need and how to approach them. So this is what it is. Thank you, Abraham, for these wonderful stories. Thank you.
Nida.
Very, very nicely put, Nida. And let's be open in full respect. Yolanda, turning to you on this same question and then coming to Nabil and then to Abraham.
Thank you. Me too, what really moves me is when Abraham shared about the view of the patient, what they have made in the healthcare setting to call them client. So this is really something really important to me, because when we are talking about client, we are not talking about making money, but we are talking about how we can be available and meet their needs. So it's like sometime even at the hospital, all the needs of our patient is something important. If my patient is, for example, most of the time I'm dealing with elderly people, I have to stand and let them in, because in like a kind of respect. And it's also, I let them time to move the way they are moving, help them get to the table for the examination. And some of them in our culture, some of them will greet you many times and ask about your family members. So it's like the way they feel. So my objective is to meet their needs. So the term, when he was talking about client, it was really something very important to me, because what I have to do is to meet the need of my patient. So every patient is specific, so I have to meet his need. For other point is when he was talking about the idea of capitalism in health system, I think that this is something like sometimes we discuss a bit, because this can happen when we are not really, in my context, if we cannot we used to say that in health care, we cannot buy health, because it's like the mean we are using. If, for example, you need an intervention and it's very expensive, or the hospital you are in, everything is expensive, but we cannot buy things dealing with her, because we cannot price. So this was, I agree, but it was like a small disagreement. Yeah, that's it.
Thank you, Yolande. Nabil, turning to you.
Yeah, thank you. I have worked as an intern house officer in a obstetrics and gynecology ward. And so what Nida was telling us was really resonating on me. But I was always worried to ask that question, because I have observed sometimes female health workers being a little disrespectful, but I was very young. So I never asked them, because we were really worried of them, actually, because I was doing our internship. But I really loved the experience that you shared, Nida. Jolande, I slightly disagree with you that you don't have your meals because you want to work for your patients. So I think you have to be compassionate to yourself, because you are so useful to your patients. So you have to look after yourself. So that is the first thing that we tell in disaster management: self-care and compassionate. And I have done the very same, what you mentioned, I have overworked so much that I got gastritis. So that is not good, because we have to be compassionate to us, so that we are so precious as healthcare workers, because we can be compassionate to others. So not pointing at you, but just to highlight the importance of self-care and having compassion to oneself. Thank you.
Thank you, Nabil. Thank you. Abraham, wrapping us up.
Well, thank you very much. I'll reflect a little bit on the little boy. It always brings joy to my heart. I don't know, there's something with the story, but it helps to keep you remembering, grounded, going back to those things that matter. Because as a child, you don't have all the privilege of, you know, discrimination, the privilege of overthinking things, right? So you just act out of spontaneity, and I can see that in how Neville expresses himself and goes about his work. I will be careful that the child in you, and as you want to do greater things and having multiple hands, always to look at that single child, not just the multitude, because it's important, as I mentioned, if you can get it right for one child, you're not going to get it right for 1,000 children. I think this is something that I would encourage you to always look at your work and keep motivated from that angle of, if I got it right for this one child, I can get it right for 1,000. And thank you, Doctor. Maybe just to clarify, Dr. Yolanda, the issue about, it's just being aware that sometimes we tend to overcalculate the cost and we forget about the human cost. So that's just what I wanted to draw the attention to. We've seen that translate. I'm sitting right now in the US, but as we go even into developing countries, we'll always look at our proposals. How much does it cost? Sometimes that's what you get when you're developing a proposal for a refugee context, for a displacement context. How much is it going to cost to build this? I tell you, the clinics that we built in Congo, that was a question that a key donor was asking us, a government donor, I'm not going to call, but they were asking us, how much is it going to cost to put that clinic? Why do you need that kind of a clinic in a place like Congo? And that was rather insulting, because if we built anything less, they would not want their child to go in that space. We would not want our children to go in that space. Then why are we starting with cost in mind? So that's the point I wanted to make. And yeah.
Thanks for that clarification. This is absolutely fascinating, and all of your perspectives are so rich. I just would like to carry on, but time is always an issue here. I'm going to ask Regina for any thoughts that she'd like to share before coming to David for any of the further questions that might come through. Regina.
Absolutely. Yeah, just that discussion was so rich. A lot of the things I picked out, like a big theme of what everybody sort of mentioned, is that just seeing people, that they exist outside of their condition or that singular interaction, and you're just seeing the whole person and really treating, when you approach someone in the way that you treat them is in regard to them as an entire person outside of that singular interaction. I know, Neville, you brought up dignity and how you really resonated with Nita's story about you know, seeing those really disrespectful sort of interactions in the hospital setting. And Yolanda, how you mentioned how you really resonated with Abraham, not seeing or referring to people as clients and customers rather than this sick person or this vulnerable person, and how just in your work also seeing people in the larger ecosystem of, okay, you've come here for this treatment, but who are the people in your life? How can I inform you more about your condition, and how can we best support you, and focus on the needs outside of, you know, this singular interaction. And so just seeing someone as whole has really come out in a lot of these stories, and also just seeing yourselves as whole, you know, so being compassionate to yourselves so that you can bring that compassion forward in the work that you do. So it's not just seeing the people that you're interacting with as a whole person, but understanding that you are a whole person deserving of the love and care and attention that you deliver, that you provide other people with. And that's how you and I love, I'm just, Abraham has got a lot of great one-liners here that if you get it wrong in one child, you get it wrong in 1,000 children. And so it's so taking the care to in every singular interaction, and seeing a person as more than just, you know, what they appear to you to be is really key, and it has come out, I guess, really well in this discussion, for me at least. Yeah, and so maybe now we pass on to David.
Thanks very much, Regina. And I'm just being told that we've got an opportunity to squeeze in another question, which I'm going to do. So, so with colleagues, I think this, I did want to come to a particular point that it would be important to hear from each of the 4 colleagues that have shared their personal experiences. They're incredibly powerful personal experiences. Why is it important to focus in on personal experiences rather than focusing in on the system as a whole? So we can be critiqued for looking at individual experiences where we actually should be looking at the system as a whole. I'm biased. I think it's really important to think through personal experiences. But in your opinion, and very briefly, why is that important to you? And we'll go in the sequence of Abraham, Yolande, Nabil, and Nida. Abraham.
Well, thank you very much. Systems did not just fall out of space. They were created by people. And we are people. It is our experiences, the biases of our experiences that we bring into that space and that crafts policy. So it is important that what we bring as individuals into this space of compassion and how that policy is going to be written, is important that we reflect personally. How do I want to be treated? If I were in the buying space, as well as if I am in the selling space of healthcare, how do I want to be treated? So it is important. I don't think that we can change the system if the people are not changed. So it's a cultural thing, and it starts with the people.
Thank you so much. And thank you, Abraham, because it was what I was about to say. And in the process of compassion, I have realized that the best way for me is like to see myself in the mirror. So what I did is like, sometimes I used to go to the hospital with someone, but I don't introduce myself as a medical doctor. So I follow all the steps to see how people are treated. And this helps me because it's a way for me to see how I can better in my practice. So I think that focusing on individual experience is really important because it helps us to build the system. So this is, to me, something very important.
Thank you, Yolande, for that. Very clear. Nabil.
Thank you. I think when you say systems, it reminds me of something rigid, something structural, something that cannot be changed. They will say we have an administrative procedure and then we have financial procedure and full stop. But I think people are necessary to melt the compartments and the crystallization that has happened. The people are stuck inside systems, but they're so hard to change or shake. But with soft power, we can do that. And that soft power comes from individuals. I can infect one person with compassion, and that person will infect another 5 people with compassion. And finally, the whole system will be infected with compassion. But it starts off with getting infected with compassion. So yeah. I think it's very important to start off with one person being infected.
Beautifully put. Nida.
Yes, so being in the positions myself, I agree that managing a program requires us to look at the system as a whole, and we do that all the time. But I strongly believe that compassion comes from within, and the greatest impact on our mind is from our own personal experiences. So if we change ourselves, this is exactly how we are going to change the world. Like Gandhi said, we must be the change we wish to see in the world.
Nida, thank you so much. It's been a privilege, really a privilege to listen to each of you. Time is short, but thank you again. And I wanted now to turn to David for his closing remarks and to take us into the conclusion. David.
Thank you so much, Shams, and thanks all of you for these really profound reflections and your inspiring stories. We have covered a lot of ground today, and we've addressed several issues that are both internal, where the compassion arises from within, as you just said, Nita, and how that can ripple out and change systems. And you've all shared examples of courage. You've been in systems that have not been compassionate. And at a certain point in time, whether it's empathy or resonating with suffering, you've stepped out of your comfort zone and taken a stand. You've realized your own agency to be true to the compassion that was welling up in you. And I just want to express my admiration for that courage. We don't often think of compassion as being courageous, but you've shared your stories that really underline how important it is to be courageous with our compassion, and to not just be guided by the behavior or the attitudes of the systems in which we're in. We had a couple of questions from the audience related to systems change, and thank you, Shams, for bringing that into our final few moments with the panelists. I want to thank all of you for your insights, for these individual stories, which have profound implications for how we develop more compassionate systems. And indeed, without the individual change, we're not going to change the systems in which we live and work. Thank you so much. I'd like to thank all four of you panelists. Regina, thank you for your reflections as well. Shams, for your great moderating and facilitation. I'd like to thank our team at the task force, Ashley, Patricia, Amy, and Hallie, for all the technical support you've provided. And Shams, I'll turn it over to you for a few final comments. Thank you.
David, I think you've said it all, and it's, as I said, a real privilege to hear from the colleagues today. Let's take those nuggets of experiences and let's utilize that for change in our world. And God knows we need all the change that we can get in the world that we're living in currently. Thank you so much, colleagues, and have a wonderful remainder of the day.